Hi, my name is Fraz Hussain. I'm one of the orthopaedic consultants here at the ROH. I'm a specialist in knee and shoulder surgery, and what we're going to be doing is going through a shoulder examination for medical students. This is our patient, this is Sarah, and the first thing you have to do in the exam is introduce yourself. So hi, my name is Fraz Hussain.
Hello.
Do you mind if I examine you?
No, that's fine.
Okay. Typical situation or cases that you'll get in the exams are things like a frozen shoulder, or osteoarthritis, impingement or instability, and we're going to focus on the examination, or more of a general examination of the shoulder. So we're going to start off with any examination in orthopaedics is to look, feel and then move on to special tests. So first of all, looking, and what you're looking for here from the front is general shoulder position, just seeing if they're rolled forward or whether in the normal extended position. Looking for the position of the neck, or if she has any disproportion on either side. She has got quite prominent acromioclavicular joints and quite prominent clavicles on both sides, but this is normal. So first of all, looking from the front, and what I'm looking for is if her clavicles are normal, if she has any muscle wasting in her deltoid muscles, and looking at her biceps muscles on both sides and her pectoralis muscles at the front. And that looks pretty normal on this side. So we're just going to get you to turn face that way. Looking from the side, again we're looking to see what the normal position of her shoulder is, and also looking at her neck, whether she's got an increase or decreased curvature of her neck. Looking from the back, we'll get you to turn and face that way. What we're looking for here is any muscle wasting, any scars from previous surgery. So you look quite closely, and what we're saying here is Sarah has an issue with her left shoulder, but what we're looking for is any arthroscopy scars, and they tend to be in this area or laterally here, or sometimes at the front as well. Any scars in the delta pectoral groove from previous surgery at the front. Looking for any muscle wasting. Now this is the area of supraspinatus, which is just above the spine of the scapula, or infraspinatus below, what the position of a scapula is, whether it's even on both sides. Now the difficulty in shoulders is there is a lot of moving from front to back, and you tend to do the majority of the examination from the back, but you also want to see if the patient's in pain when you do those movements. So either have a mirror in front or say to the patient, I'm going to be moving your shoulder. If I cause you any discomfort, please do tell me, as I won't be able to see. Okay, so starting off with palpation, what I do is I start off from the back and compare both sides, and we're going to start off on the medial side of the scapular border and see if there's any tenderness around there. Feel along the spine of the scapula and across the acromion, over to the acromioclavicular joints, and the same on the other side. Now with any shoulder examination you should always examine the neck, so I'm just going to briefly just do a screening test of the neck. So we're going to feel for any tenderness along the cervical spine. Is that tender at all?
No.
Okay, and we're just going to do the movements of the neck so we get that out of the way. You can either do that at the start or at the end, but you should always do a cervical spine examination as part of your shoulder examination. So I can get you to look up at the ceiling, and down at the floor, and cross to the right shoulder, cross to the left shoulder, make your ear touch your left shoulder, and make your ear touch your right shoulder. Now, did any of those movements cause you any discomfort down the shoulder, bring on your symptoms, or cause any pins and needles?
No.
Okay, fine. Can I get you to turn towards me now? And what we're doing here is continuing with a palpation, just feeling around the edge of the acromion, up to the acromioclavicular joint. Is that tender there at all?
No.
Okay, across the front of the clavicle, and over to the sternoclavicular joints. Is that tender?
No.
Fine. The axillary nerve can become injured, and that will cause some numbness around the badge area here, and you have to feel for any numbness in that area. Is that normal there?
It's normal.
Okay, and that feels the same down there?
Yeah.
Okay, fine. Get you to turn round to the front now, and we're going to carry on with the palpation, see if there's any tenderness around that area over the sternoclavicular joints. So we've completed the look and the feel. We're now going to ask her to move. So I can get you to turn around and face the wall again. We're going to start off with forward flexion. So if I can get you to raise your arms in front of you, right up to the ceiling, and back down again. Okay. And what we're looking for here is looking at the general scapulothoracic movements and what proportion of the movements is brought on by the glenohumeral joint, as well as the range of movements that she's got. So actively she can elevate right the way up, but if she can't, and it's important to check passively if you can get any further, but again, you don't want to cause the patient any pain, so you say to them, if it causes you any pain, please tell me. Okay, well, she can get right the way up passively as well. We're just going to repeat that elevation. Can I get you to do that again, but more slowly? And you can see at the initial bit of the movement, it's glenohumeral, and as she gets up further, scapulothoracic movement comes in, and then she moves it right the way up. And as she comes back down again, just checking she hasn't got a hitch, and she's got normal shoulder rhythm there. On abduction, bring your arms up at the side, bring them right the way up, and clasp your hands together, and bring them back down again. And again, she's got full abduction and elevation, and a normal scapulothoracic rhythm there. Can I get you to turn and face me now? And what we're going to check here is external rotation. Just get you to face forward, tuck your elbows in, and just turn your arms out. And what we're looking for here is external rotation. This is typically reduced with a frozen shoulder, any capsular tightness or osteoarthritis. You start off with a zero position and you bring it out, and in her case, in Sarah's case, she's bringing it out to around 60 degrees of external rotation, and you compare that to the other side, just getting around to about 60 degrees. You can do that actively and passively. Can I get you to turn around and face the wall now? Internal rotation. On this side, just show me how far you can get your arm up the back. And what you're doing here is measuring the internal rotation by marking the centre of the hand and then counting it down from the 7th cervical vertebra, just as a measure of how far she can bring it round. Do the same on this side. And this one isn't getting up as high, so she has some reduction in internal rotation on the right side. Just get you to turn around and face the camera again. Similarly, you can just assess internal rotation, bring the arm out to 90 degrees, and just seeing how much internal rotation she's got there. And you compare that to both sides, bring that up, and internally rotate. So we've done the movements. We're now going to do some special tests. And the first of these is checking for impingement. Now, what impingement is where the underneath the acromion you have a bursa that sits between that and the rotator cuff muscles, and that can become inflamed. And the way to see if she has got that is to do some impingement testing. The first of these is Neer's sign, which is where you internally rotate the arm and elevate it in line of the scapula. Now, again, just tell her that this may cause her discomfort, and just tell me if it causes you any pain as you bring it up. And just elevate it right. This is a passive test as you bring it up. Does that cause you any pain at all? Okay. Now, typically with impingement, they have a painful arc, and it's not painful initially until they get to around about 50 or 60 degrees. It causes them discomfort, and it's painful right the way up until they're past around 110, 120 degrees, and then they're free of pain. With a high painful arc, it typically happens if they've got an issue with the acromioclavicular joint as well. Second test for impingement is Hawkins test, and the way we do that is to abduct the shoulder to 90 degrees and internally rotate and see if that causes any discomfort. And what we're doing here is bringing the tuberosity up under the acromion to really squeeze out that bursa to see if that causes any discomfort. Is that painful at all?
No.
And we're trying that in different degrees of internal rotation of the shoulder and see if there's any point at which it can impinge, because the acromion can be quite a wide area and it can be different areas where the impingement occurs. Going on to acromioclavicular joint, if she has any tenderness over there, we can do a provocation test, something called a scarf test, which is where you elevate the arm to 90 degrees and bring it across the chest. You should have 90 degrees between the arm and the torso, and bring that across and see if that causes any discomfort. Is that painful at all?
No.
Okay, fine. We're then going to go on to test the rotator cuff muscle. So if I can get you to turn and face me. The first of these is supraspinatus, and the way we do that is to internally rotate the arms, elevate to around 30 degrees, and just get it to push up against me. So what I want you to do is to try and bring your arms up towards the ceiling as I push down, and you just feel the difference on either side if she has any weakness. That's for supraspinatus. Going on to infraspinatus, we bring the elbows in, And what I'd like you to do is to push my hands apart. We're just seeing if there's any weakness in external rotation. With subscapularis, if I can get you to your arm behind your back and just push against my hand there, just seeing if there's any weakness in subscapularis. If they're unable to get their arms behind their backs, put your hands on your tummy, bring your elbows forward and just hold it there. Does that cause any pain? And there's no weakness there either. So that completes the examination for a frozen shoulder, osteoarthritis or impingement, and what we're going to do now is move on to some specific tests for instability. Now you do these typically after you've done the full range of movements and testing for weakness in the rotator cuff muscles. We're now going to go on to testing for apprehension. You may not be asked to do this in the exam because it is quite an uncomfortable test. So the first thing you do is you have the patient relaxed on the couch and just ask them to tell you if they're causing you any discomfort. Is this causing you any problems?
No.
So the arm comes round into the abduction external rotation position and you just gently externally rotate, making sure you're looking at the patient, and if it causes them any apprehension symptoms or discomfort, then you stop. You then apply a force on the front of the humerus to try and reduce any subluxation and see if it rotates any further. It's a difficult test to do and you may not be asked to demonstrate that in the exam, but you should understand the principles behind it. Now what we're going to be doing is some specific tests for instability, and the first of these is a sulcus sign. Get the patient nice and relaxed, preferably in a sitting position. What we're looking for is this area here below the acromion. And what we do is get a nice and relaxed, just tell me if I cause you any pain, but try and relax your shoulder. And as you're stabilising the scapula and the acromion, you're pushing down on the humerus. And as we pull down, you can see that she's just opening up here. You can see the edge of the acromion there, and this is the area you're focusing on. You can see that quite nicely here. This is a normal sulcus sign here. We're now going to look for any anterior translation. So again, I'm stabilising the scapula, and what I'm going to do is just see if the humerus moves forward on the glenoid. So I'm just going to apply some force. Just tell me if this is painful at all. And if it is painful, then stop, because sometimes it can be a painful test. So I'm just pushing the humerus forward and back, and she doesn't have any anterior translation. Okay.